All right. Good evening, everybody. My name is Michael Awad. I'm a minimally invasive surgeon at Washington University in St. Louis. Your host for the webinar this evening. I'm very excited to have you all join us for part 2 of our longstanding SAGES SCORE resident webinar ABSITE review. So this webinar is something we've been doing for several years, and to help folks that are preparing for the ABSITE have just another resource and additional study material. We've been doing this for a number of years, and tonight we're excited to have about 1,000 folks from all over the world joining us on the webinar tonight. So I'm going to go through a few things, and then we'll dive right in as we've got a lot to go through. So first, overview of our schedule. I'm fortunate to be joined by a fantastic set of faculty who will be going through the ABSITE questions and also some tips and tricks and pointers as we're going through it. So we're going to be starting with surgical critical care and trauma, breast and endocrine, pediatrics, transplant, thoracic and plastics, and then finally vascular. I want to acknowledge SAGES. SAGES has been the host of this webinar for many years. SAGES is the Society of American Gastrointestinal and Endoscopic Surgeons. SAGES not only puts on this webinars, but has a tremendous wealth of resources for trainees, residents, fellows, as well as practicing physicians in minimally invasive surgery and endoscopic surgery education. The next SAGES meeting is in Cleveland, Ohio in April. Very much looking forward to it, and I hope that many of you can join us there as well. I also want to acknowledge SCORE, which is the Surgical Council on Resident Education. This is one of the most pervasive national curricula for surgical trainees that there is. We've partnered with SCORE the last couple of years, who have been providing some of the high-quality questions that you're going to be seeing here tonight. To note, one of the things that we've heard based on popular demand is the webinars are great, but we'd like more of them. So this year we expanded to 2 parts. Back in December, we had the first part, which covered the abdomen and alimentary tract, and that's something that's going to be on the YouTube and the SAGES channel. You can review that if you'd like to go back and see that. Tonight we're going to be covering part 2, which you'll see covers the rest of the topics that are high yield. Together, between the 2 webinars, we will have covered about 3/4 of all the topics that are on the ABSITE. So the format, we're going to be going through pretty rapid-fire multiple-choice questions, and to make it more interactive, we're going to use an audience response system called Poll Everywhere. So I'd like folks, if you haven't already, you can participate in one of these 2 formats. You can go to pollev.com/ABSITE, pollev.com/ABSITE, or you can text the word ABSITE, ABSITE, to 22333, and then you can enter your responses with the letters provided. And then after each of the questions, we're going to be going through some explanation with rationale as well. If you lose all your video, just exit the webinar, close out of your browser, and open up your browser and log back in. If you still have problems, restart your machine. At the end of the webinar, there's going to be a web link to a survey. We read all of those survey responses, so we appreciate if you can just take 30 seconds to complete that survey and let us know how we did. And then, like I mentioned, these webinars are being recorded, and you'll be able to review them online at www.sages.org within the next 2 weeks. All right, so we're going to kick off with our first topic tonight, which will be surgical critical care and trauma. Leading us through those questions and discussions is Dr. Ivy Haskins from University of North Carolina at Chapel Hill, who's been on our resident and fellows training committee. Welcome, Dr. Haskins.
Okay, so we'll start with the first question. You have an 18-year-old woman with a history of peanut allergy who is brought to the emergency department after accidentally eating a chocolate bar containing peanuts. Her presentation consists of urticaria, diffuse itching, facial swelling, and inspiratory stridor. What is the correct dose of intramuscular epinephrine that must be given to this patient? The options are 0.5 milligrams, 1 milligram, 0.3 milligrams, or an infusion of 5 micrograms per minute. Okay, good. So it looks like a majority of you got the right answer. I think for this question, it's really just memorization. So a 0.5 milligram dosing is the IV dose that you give for someone who's having anaphylaxis. 1 milligram is the dose that you give to someone who is pulseless and you're performing ACLS protocol on. 0.3 milligrams is the correct dose for intramuscular epinephrine. The infusion dose is a reasonable dose that you can start a patient on who's in anaphylactic shock who will end up on epinephrine. And 0.1 mg per kg is a pediatric dosing. Okay, next question. A 45-year-old man with a penicillin allergy accidentally receives a dose of Unison for treatment of an abscess and develops urticaria, facial swelling, hypotension, and respiratory failure. He is immediately intubated, given crystalloid infusion, intramuscular epinephrine, inhaled albuterol, and IV methylprednisolone, but his hypotension remains persistent despite all of these interventions. What is the vasopressor of choice for this patient in refractory hypotension? Your options are norepinephrine, vasopressin, dopamine, epinephrine, or phenylephrine. Ooh, good. It looks like we have some topics to discuss. So the vasopressor of choice is similar to the medication that you would give either IV or intramuscularly, similar to our previous question. So the answer is actually epinephrine that you give to someone in anaphylactic shock. Norepinephrine is your first-line vasopressor for someone who's in septic shock. And vasopressin can be added to norepinephrine kind of to augment someone's response to norepinephrine or if they have refractory septic shock. Dopamine is used for patients who are hypotensive and also bradycardic. And phenylephrine is kind of used in someone who doesn't necessarily have central access but who is hypotensive. Okay, next question. A 50-year-old obese man with a history of posterior spinal fusion presents to the emergency department with angioedema and respiratory failure after a bee sting. 2 attempts of endotracheal intubation are unsuccessful and the patient's oxygen saturation via pulse oximetry is 60%. What is the next best step in the management of this patient? A, administer epinephrine via a nebulizer and make another attempt at endotracheal intubation. B, insert an LMA. C, place the patient on continuous positive airway pressure ventilation. D, consult anesthesiology for an emergent fiber optic intubation. Or E, perform a cricothyroidotomy. Good. So this patient is losing their airway quickly, and as we all know from our trauma ACLS protocol, airway is the first step in your kind of workup of this patient, so securing the airway is the most important. And you've already had 2 failed attempts at endotracheal intubation, so a surgical airway should be performed next. Next, a 57-year-old man presents to the emergency department after falling from a ladder. He has an obvious deformity of both lower extremities below the knees and is reporting lower back pain. What sign in this patient would be considered a hard sign of vascular injury? A, neurological deficit, B, audible bruit, C, diminished pulse, D, history of significant bleeding, or E, injury proximal to a major vessel.
We didn't get the responses registered for that one, Ivy, but we do have some nice slides that you provided to go over as well here too.
Okay. So these slides pertain to the next two questions. I actually just took the written board exam and the oral board exam in the past year. So knowing your hard and soft signs of vascular injury are important. It's guaranteed to come up on all of the tests, so the ABSITE as well as the board exam. So this is really just knowing the difference between the hard and the soft signs. And again, unfortunately, a lot of this is memorization. So a hard sign of vascular injury is an audible bruit. In any patient who has a hard sign of vascular injury, they need to go to the operating room. So doing a workup, checking their ABIs, doing an angiogram, this delays the time to reperfusion and kind of puts them at risk of developing compartment syndrome and other issues along down the line. So we have one more question about signs of vascular injury. A 28-year-old man is brought to the emergency department after sustaining a gunshot wound to the anterior medial thigh. He has a large hematoma but is hemodynamically stable. What finding in this patient would be a soft sign of vascular injury? A, absent distal pulse, B, audible bruit, C, palpable thrill, D, injury proximity to a major vessel, or E, expanding hematoma.
Ivy, while people are thinking about that one, there was something in the chat room about, was it bruit or diminished pulses, as both were under hard signs?
In terms of what? What the hard sign was?
Yeah. Yeah.
Yeah. So in someone who's 30 years old and doesn't have a distal pulse, that's a hard sign of vascular injury. It's a little bit of a gray zone because a lot of times in patients who don't have active hemorrhage in the area of a vessel or have an expanding or pulsatile hematoma, the first thing most people do is an ABI. And so I guess that could kind of be included as a diminished pulse. And that's a soft sign if their ABI is less than 0.9, meaning it's abnormal. But really what they're looking for is someone who should have a pulse and it's not present. I don't know if that explains the answer.
Okay, here's the answers for this last question.
Okay, so all the other answer choices are hard signs of vascular injury. So the only soft sign of a vascular injury is that you have an injury that's in the location of a major vessel. Okay, a 60-year-old man suffers a 60% total body surface area burn injury and a house fire and is brought to the emergency department. What is your initial approach to evaluating and managing this patient? A, evaluate the patient's airway status. B, calculate the resuscitation volume needed for this patient using the Parkland formula. C, start lactated ringers at 200 cc's an hour. D, obtain a chest x-ray. Or E, obtain a medical history.
Wow. Grand slam on that one.
So good. This is your standard trauma patient. So a lot of times in the question set, they will give you something that they would hope to throw you off. Obviously, you guys did not get thrown off on this. So any trauma patient, regardless of their mechanism of injury, it's always per ATLS protocol. So airway, breathing, circulation. A 64-year-old man with past medical history of hypertension, hyperlipidemia, diabetes, coronary artery disease, and peripheral vascular disease is sent to the emergency department from his nursing home for evaluation of a wound on his right foot. On examination, his vitals are stable. He has a 3 by 2 centimeter plantar wound on the right foot that has no purulence or necrotic material. He reports the wound has been present for 6 months. At what stage of healing is the wound? A, hemostasis, B, inflammatory, C, proliferation, D, maturation.
Question there.
Okay. So at least one question on wound healing is bound to come up on the ABSITE. So I think it's important that we review the phases of wound healing first. Dr. Awad, do you have my slides?
Sure do.
Okay, perfect. So the first phase is hemostasis, really where your platelets are coming in to help kind of recruit other active players in the wound healing process and to control any injury that has occurred in the tissue. The second phase is the inflammatory phase, again, where most of the important cell players are coming in, and you're developing kind of a new framework and nutrients to help heal the wound. If a wound is stuck in wound healing, it's often occurring in the inflammatory phase, meaning that there's something that's happening, as in the patient doesn't have adequate nutrition or there's something in the wound that's preventing the wound from healing itself. If the wound is healthy and it has all the key players, you can proceed from inflammation to proliferation and then remodeling. So the answer to this question is actually that the patient was stuck in the inflammatory phase of the wound healing. The other slide that I have just talks about things that are important in terms of your ABSITE. So typically they will ask you about the types of collagen in wounds. Just remember that it's type 3 collagen in a new wound that then converts over to collagen type 1, which is the most common form of collagen in any wound or tissue. And then the second bullet point is the order of the important cells that come into the wound. Okay, a 33-year-old man with a 4-year history of paraplegia secondary to a gunshot wound presents to the emergency department after his home nurse found the patient's febrile. The patient has a temperature of 102.2, a heart rate of 105, blood pressure of 125/98, respiratory rate of 16 breaths per minute, and an oxygen saturation of 99%. On physical examination, he is noted to have a 10 by 8 centimeter sacral decubitus ulcer to a subcutaneous tissue depth. The wound base is pale with fibrinous material, and when it is explored, a small amount of pus is expressed. What is the next best step? A, discharge with local wound care instructions to change moist to dry gauze dressings twice daily. B, admit with plans for topical enzymatic debridement ointment and oral antibiotics. C, admit for wound vac placement and IV antibiotics. D, admit for immediate surgical debridement in the operating room. Good. So this patient is showing signs of sepsis. And as we know, the Surviving Sepsis campaign, the most important tenet is source control. So this patient needs wide debridement of their decubitus ulcer to make sure that their infection is addressed. A 32-year-old woman presents to your clinic 2 months after cholecystectomy. Her procedure was converted from laparoscopic to open. She has concerns regarding her surgical site. On physical examination, you note a right upper quadrant surgical scar with excess scar tissue formation. The tissue remains within the boundaries of the surgical incision. What is an accurate statement regarding the histopathology of this condition? A, this condition is made up of organized type 3 collagen. B, this condition is made up of disorganized type 1 and type 3 collagen. C, the collagen fibers of this condition have increased tensile strength compared with uninjured tissue. D, this condition has a genetic etiology. Okay, so the answer is actually A. So the first part of figuring out this question is to recognize what type of scar you're dealing with. So this is actually a hypertrophic scar because it stays within the borders of the actual scar itself, compared to a keloid scar that kind of goes over the boundaries itself of the scar. A hypertrophic scar is made up of organized type 3 collagen, and over the course of time, it kind of resolves on its own. A keloid scar is made up of disorganized type 1 and type 3 collagen, which is answer B, which is what a lot of you put. A keloid has a genetic basis, while a hypertrophic scar does not. And all scars in general have decreased tensile strength compared to uninjured tissue.
Dr. Haskins, there's some questions on the bulletin board about your previous question on wound healing where you showed the figures. The questions were, how do we know that this is an inflammatory stage he was stuck in and not proliferative stage, for example?
So you have to have all the key players to make it from the inflammatory phase to the proliferation phase. So the fact that the patient's not showing any progression of wound healing signifies that the patient has not progressed along the pathway of wound healing. And in order to get from the inflammatory stage to the proliferation stage, you have to have the right cells and the wound itself has to be clean. So based on those patients' medical comorbidities, my assumption would be that they don't have great blood supply, which means that the platelets and the neutrophils and the macrophages and the fibroblasts that are needed to help with the wound healing haven't successfully made it into the wound to help reorganize the wound itself and to start the proliferation phase.
Thank you.
Okay. A 33-year-old woman with a history of ulcerative colitis who is currently on budesonide presents for excision of a cyst on her upper back. The operation is uncomplicated and she is discharged home. At her 1-week follow-up visit, you inspect the incision site. The wound edges do not approximate. There is minimal granulation tissue. There is no purulence or exudate. What will you describe to aid this patient's wound healing? So this patient is on a steroid, and the best medication to counteract the effects of steroid stalling on wound healing is actually vitamin A, which is answer choice B. A 24-year-old woman presents to the emergency department after jumping through a first-floor window. She is in stable condition. Her only major injury is a large stellate laceration on her right forearm. There is no active bleeding. What is the best next step to manage her wound? A, trim jagged skin edges to avoid necrosis. B, perform thorough irrigation with sterile saline solution. C, place packing strips into the wound. D, administer an antibiotic ointment to the wound base. Good. So that's the correct answer. So once you've achieved hemostasis, the next thing to do is to thoroughly irrigate the wound, especially in someone who's jumped through the first floor of a window. You want to make sure that they don't have any retained foreign bodies, which would serve both as a nidus of infection and prevent wound healing. So again, this is kind of another opportunity where a patient would end up stuck in the inflammatory phase of wound healing. A 29-year-old man is brought in by emergency medical services after sustaining a gunshot wound to his chest, located 1 centimeter to the right of his sternum. His heart rate is 90 beats per minute. His blood pressure is 108/78, and he is speaking in full sentences. His wound is not bleeding. Chest X-ray reveals a metallic fragment overlying the cardiac silhouette, and a fast exam is consistent with a pericardial effusion. What is the most appropriate next step? A, proceed to the operating room for a median sternotomy. B, proceed to the operating room for a left anterolateral thoracotomy. C, admit to the trauma ICU with telemetry and repeat the fast exam if he becomes hemodynamically unstable. D, perform median sternotomy in the emergency department. Or E, perform left anterolateral thoracotomy in the emergency department. Dr. Awad, do you have my slides?
Let's see. Here we go.
Okay, perfect. So this question and a few more questions that we'll talk about are discussing box injuries. So the borders for your box injury, clavicle superiorly, subcostal margin inferiorly, and your nipples laterally. So any injury that falls within the box requires a workup and further evaluation. These patients cannot be admitted to the ICU because they will end up dead. Give the next slide, perfect. So in a patient who is unstable, they get the ED thoracotomy. That's your left anterolateral thoracotomy. This patient is not unstable. So the first part to a patient, this kind of workup gets a little bit confusing, but in someone who's stable, they either get a pericardial window to check for blood within the pericardium, or they get a tube thoracostomy. And the reason why I say that is because most of these patients come in with a hemothorax. If you have significant output from your tube thoracostomy, meaning 1,500 at the time of insertion, or more than 500 cc's per hour for the next 2 to 3 hours, they end up in the operating room. In a patient who ends up having a positive pericardial window, they also get a median sternotomy, so they get an operation as well. So these patients can't be watched because most of them will end up in pericardial tamponade. So the answer for this question is to proceed to the operating room for a median sternotomy. Next question, a 48-year-old man is stabbed in the left chest 2 centimeters lateral to the sternum. He is brought in by emergency medical services with agonal breathing, and he loses pulses during the initial assessment. He is intubated and has bilateral breath sounds. What is the next best step in management? A, proceed to the operating room for a median sternotomy. B, proceed to the operating room for a left anterior lateral thoracotomy. C, perform a bilateral tube thoracostomy in the emergency department. D, proceed with central line placement to ensure adequate IV access. Or E, proceed with a left anterior lateral thoracotomy in the emergency department. Good. So this is your traditional standard ED thoracotomy. Again, it's a box injury. So the best evidence for an ED thoracotomy is someone who has penetrating chest injury, who loses signs of life either in front of you or within 10 minutes of arrival to the emergency department. An 18-year-old man presents after accidentally being shot with a bow and arrow. His wound is in his left chest, medial to the nipple. His heart rate is 118, blood pressure 90/56, O2 sat of 87% on 2 liters of oxygen by nasal cannula, and he is speaking in full sentences. He has muffled heart sounds and jugular venous distension. A chest X-ray reveals a large left-sided pneumothorax. Cardiac fast exams reveals a thick black line outside the heart and within the pericardium. What is the next step in management? A, proceed to the operating room for a median sternotomy. B, proceed to the operating room for a left anterior lateral thoracotomy. C, perform a left-sided tube thoracostomy. D, admit to the trauma ICU for close monitoring. Or E, obtain a CT scan to better characterize injuries and aid in preoperative planning. Good. So this is a polytrauma patient, and the answer kind of depends on what is going to kill the patient first. So he is showing signs of a tension pneumothorax. So the first injury to address is the tension pneumothorax. Ultimately, this patient will end up in the operating room for their cardiac injury, but in order to prevent them from coding, you need to place a tube thoracostomy. A 23-year-old man presents after he fell out of a tree onto a chain link fence post. His wound is in his left chest, medial to the nipple. His heart rate is 135 beats per minute. Blood pressure is 88/42. Oxygen saturation is 95% on 6 liters of nasal cannula. He is speaking in sentences of 5 to 6 words. Chest X-ray reveals a right-sided hemothorax, and a fast exam does not reveal free fluid within the pericardium. But the wound is suspicious for a cardiac injury. What is the next best step in management? A, proceed to the operating room for a median sternotomy. B, perform a resuscitative thoracotomy in the emergency department. C, perform a right-sided tube thoracostomy as definitive treatment. D, admit to the trauma ICU for close monitoring. Or E, obtain a CT scan to plan preoperatively and better characterize injuries.
And while folks are chewing on that, apologies, we had a couple slides where the last part of the question stem was cut off. The reader, the presenter will read the full question, so just listen in to the presenter's full reading of the question. Apologies for that.
All right, it looks like you guys have box injuries down. So again, this is an injury inside the box, and you have a high suspicion for a cardiac injury. And someone who's stable, again, you could do a pericardial window first. And if that's positive, then proceed to a median sternotomy. That's not an answer choice, so the best answer choice is to do a median sternotomy. A 56-year-old woman was stabbed in the chest and required operative repair of a cardiac injury 3 days ago. There was no involvement of coronary vessels in the repair. Today, she reports experiencing shortness of breath and chest pain. She was not experiencing these symptoms yesterday. What is the next step in management? A, reassure that this is expected after her injury and surgery. B, obtain a chest x-ray, EKG, and echocardiogram. C, obtain chest CT angiography. D, treat her symptoms with morphine. E, call cardiology consultation and start a heparin drip. Good. So you want to obtain a chest x-ray, EKG, and echocardiogram. You don't totally know what's going on with this patient, but you need to rule out an arrhythmia, a thrombus, or pericarditis, and these tests will help you do that.
Dr. Haskins, I want to thank you very much for leading us through that high-yield section of acute care and trauma. That was an excellent review. Thank you very much for that.
Thank you.
I want to move on to our next section. Dr. Amy Rosenbluth from UT Southwestern will be leading us in another high-yield topic on breast and endocrine. Welcome, Dr. Rosenbluth.
Thanks. Thanks so much. Can everyone hear me?
Yes.
Great. Okay, so the first question, on a screening mammogram, a 52-year-old woman has suspicious microcalcifications in the lower outer quadrant of her left breast. What is the next step in the workup of this patient? A, ultrasound, B, fine needle aspiration, C, diagnostic mammogram followed by core biopsy, D, core biopsy, or E, excisional biopsy. Excellent. So the first thing you can rule out, because this is a breast question, so we're not doing fine needle aspirations, and in general, we're not doing excisional biopsies as the first step. The first thing you want to go with are core needle biopsies. Also, if something's picked up on a screening mammogram, the next step is a diagnostic mammogram. That way you can get a more magnified and detailed view of the pathology. Ultrasound is not really sufficient to evaluate the pathology with microcalcification. So good job, guys. So the next question, a 60-year-old woman with 1 centimeter suspicious microcalcifications on diagnostic mammogram is found to have a high-grade estrogen receptor negative ductal carcinoma in situ, DCIS, on stereotactic core biopsy. She undergoes a segmental mastectomy, and the surgical pathology shows one margin with tumor cells 1 millimeter from the ink. What is the next best step in treatment of this patient? A, radiotherapy, B, aromatase inhibitor, C, mastectomy, D, re-excision of the close margin, E, surveillance with bilateral diagnostic mammogram in 1 year. Great, so this is DCIS. You need 2 millimeter margins for this, so the next thing you want to do is re-excision of the close margin. That's exactly right. A 55-year-old woman presents with extensive microcalcification spanning 2 quadrants of the breast on diagnostic mammogram. Stereotactic core biopsy shows DCIS. What is the most appropriate treatment option for this patient? A, segmental mastectomy, B, segmental mastectomy followed by radiotherapy, C, unilateral mastectomy, D, unilateral mastectomy with sentinel lymph node biopsy, or E, bilateral mastectomy. Good. So the key factor in this question is that it's DCIS in multiple quadrants. So breast-conserving therapy would be considered disfiguring. She needs to have a mastectomy. And when doing the mastectomy for DCIS, you need to do the sentinel lymph node because there's about a 20% upstaging to invasive cancer from DCIS. And if you don't perform the sentinel node at the time of the mastectomy, you won't be able to go back and do it. You can't stage it properly. Okay, 65-year-old woman presents with 3 centimeter of fine linear pleomorphic microcalcifications on diagnostic mammogram. The initial stereotactic core needle biopsy does not show any microcalcifications, and the second core biopsy shows benign breast changes on pathology. What's the next appropriate step in the management of this patient? A, fine needle aspiration. B, repeat stereotactic core needle biopsy. C, excisional biopsy. D, mastectomy. Or E, 6-month follow-up with a diagnostic mammogram. Awesome. You guys are doing great. So pleomorphic calcifications are not benign, so it's a discordant finding. You can't just follow it. And remember, it's breast, so we're not doing FNAs. You already have 2 negative stereotactic biopsies, so going back for another one is not a great idea. Don't repeat it. Go on to an excisional biopsy. A 41-year-old woman undergoes a total thyroidectomy for a 2.3 centimeter right papillary thyroid cancer. Which of the following markers can be used to determine disease recurrence? A, calcitonin, B, thyroglobulin, C, carcinoembryonic antigen, or D, thyroid-stimulating hormone. Awesome. The key in this is papillary thyroid cancer, so thyroglobulin. Calcitonin is used for medullary. CEA is used for medullary. TSH isn't used to follow. It's produced by the pituitary, so that wouldn't be good. Thyroglobulin is your answer. A 26-year-old man is found to have a 1.8 centimeter left thyroid nodule. Neck ultrasound shows no lymphadenopathy. FNA reveals a follicular lesion. What is the appropriate surgical management for this patient? A, total thyroidectomy. B, reassurance and no further intervention. C, total thyroidectomy with left central neck dissection. Or D, a left thyroid lobectomy and or molecular marker testing. You guys are doing awesome. When you see follicular on a thyroid biopsy, you can't know if it's benign or malignant, so traditionally that means the lobectomy is your next step and a return to the OR if your lobe is malignant. There's also molecular markers you can send for, so that could show up as an answer. But because it could be malignant, you can't just reassure, and similarly, because it's benign, a total thyroidectomy would be inappropriate. Okay, a 44-year-old woman presents with a small right thyroid nodule without cervical lymphadenectomy. Ultrasound shows a 0.8 centimeter cystic hyperechoic nodule with smooth margins. What is the next most appropriate step? A, observation, B, right lobectomy, C, total thyroidectomy, or D, fine needle aspiration. So the correct answer is A, observation. A sub-centimeter thyroid nodule is generally observed without a need to biopsy. Additionally, smooth margins, cystic and hyperechoic nodules, those are benign signs. Certainly there would be no reason for a lobectomy or a total thyroid. Malignant features or a larger nodule would warrant an FNA. Okay, a 62-year-old woman comes to the emergency department with altered mental status, myalgia, oliguria, a serum calcium level of 14.5, and a parathyroid hormone level of 300. What is the next best step in treatment? A, bisphosphonates to reduce further calcium reabsorption from the bones. B, IV fluids. C, loop diuretics. D, sestamibi scan to localize the abnormal parathyroid gland. Or E, ultrasound of the neck to look for parathyroid lesions. Awesome, you guys got it. This is one of those next best step questions. So the next best step is going to be fluid resuscitation. Once they've gotten resuscitated, then you'd start the loop diuretics. Once you've treated that, then you can start working up the reason for their hypercalcemia. A 55-year-old man presents to your office for consultation regarding suspected parathyroid carcinoma. His serum calcium is 14.7 and his parathyroid hormone is 314. Limited ultrasound shows a 1.5 centimeter loculated lesion in the right superior gland with a thick capsule. No further workup has been performed. What is the next best step in management? A, fine needle aspiration biopsy of the lesion. B, core needle biopsy. E, en bloc resection of the lesion and surrounding structures. C, en bloc resection with ipsilateral neck dissection. Or E, follow-up ultrasound in 3 months to evaluate the lesion. Okay, a little bit of debate on the answer of this question. The correct answer is en bloc resection of the lesion and surrounding structures. So in this patient, you're already suspecting parathyroid carcinoma, so following up in 3 months is not appropriate. There's no reason to biopsy. It's actually contraindicated because it can seed the biopsy tract and because the tissue that you get from the biopsy usually isn't sufficient. Additionally, a neck dissection is not indicated if there's no obvious nodal disease. A 49-year-old woman is undergoing parathyroidectomy for suspected parathyroid adenoma. Intraoperative evaluation of the lesion reveals 1.6 centimeter firm mass. Closer inspection reveals possible invasion to the ipsilateral thyroid gland. What is the correct next step for managing this patient? A, parathyroidectomy and ipsilateral thyroid lobectomy. B, parathyroidectomy and total thyroidectomy. C, complete parathyroidectomy and wait for final pathology to decide adjuvant treatment options. D, parathyroidectomy, ipsilateral thyroid lobectomy, and ipsilateral neck dissection. Or E, parathyroidectomy with intraoperative parathyroid hormone evaluation to assess for complete resection. Great. So en bloc resection of the tumor is the treatment for parathyroid carcinoma. There's no great adjuvant treatment, so you need to take the thyroid lobe that's being invaded. A total thyroidectomy and a neck dissection would be overkill for the patient that they're describing.
Dr. Rosenbluth,
Yes.
going back to our previous question, there was something in the chat room about the indications for lobectomy versus total thyroidectomy for follicular cancer, especially in the context of molecular testing.
Sure. So for follicular for the follicular cancer, if it comes out to be cancer, you're going to go back and do the total thyroidectomy. The molecular testing is kind of risk stratifying, and I don't think that they're going to get as into the weeds with that on the ABSITE as to say whether you should initially do a total thyroidectomy or not, but it could show up in the questions that molecular testing is possible.
Thank you.
A 37-year-old woman with a history of prolactinoma and a prior subtotal parathyroidectomy for hyperparathyroidism presents to the emergency department for abdominal pain. An abdominal CT scan reveals a 2-centimeter pancreatic mass. Which of the functional neuroendocrine pancreatic tumors is most likely? A, gastronoma, B, insulinoma, C, glucagonoma, or D, VIPoma? Great. So the key to this question is that it's pituitary, parathyroid, and pancreas, so MEN1. The most common functional pancreatic neuroendocrine tumor in a patient with MEN1 is a gastronoma, about 54% of them, followed by insulinoma, then glucagonoma, then VIPoma. A 55-year-old man presents for further workup of his gastric reflux that has been refractory to PPIs. A secretin test is performed. What change from the basal fasting gastrin level is indicative of a gastronoma? A, a drop in gastrin by 120 at 15 minutes. B, an increase in gastrin by 120 at 10 minutes. C, a drop in gastrin by 20 at 5 minutes. Or D, an increase in gastrin by 20 at 2 minutes. Great. This is a little bit of one of those you just have to know it questions. If it's a gastronoma, a secretin test should make the gastrin level increase, not decrease, and it'll usually peak at about 10 minutes, and the number is 120. A 69-year-old woman presents to the emergency department after a motor vehicle crash. CT of the abdomen reveals no acute traumatic injury. However, a left adrenal mass is noted incidentally. Which of the following CT findings is concerning for malignancy? A, rapid contrast washout on delayed imaging. B, evidence of high lipid content. C, measurement of 45 Hounsfield units. Or D, a size of 2.5 centimeters. All right, some debate on this question too. So adrenal lesions measuring less than 10 Hounsfield units are generally universally benign, and you'd see that with high lipid content. Carcinomas are generally more than 20. Other concerning findings are if they have calcifications, are larger than 4 centimeters, or are unilateral or heterogeneous. So measuring 45 Hounsfield units is the most concerning part for malignancy. Rapid washout is not concerning. A 59-year-old woman undergoes an open left adrenalectomy for suspected adrenocortical carcinoma. Unfortunately, during the manipulation of the gland, tumor rupture and spillage within the abdomen occur. What is the recommended adjuvant therapy? A, midotane monotherapy. B, surgical resection. C, chemotherapy alone for systemic control. D, radiotherapy for local control. Or E, radiofrequency ablation to the site of spillage. Yeah, so midotane. Surgical resection, the definitive management for adrenocortical carcinoma. Midotane has been shown to improve overall survival overall survival, and it is what you would use if you were treating for tumor spillage. Chemotherapy can be added to augment this, but it wouldn't be the definitive management for it. Radiotherapy and radiofrequency ablation don't have any role. A 72-year-old woman with a medical history of renal cell carcinoma 5 years ago presents to her primary care provider with complaints of unintentional weight loss and vague abdominal pain. A CT scan reveals a 4-centimeter heterogeneous adrenal tumor on her right gland. What is the most appropriate next step? A, fine needle aspiration. B, PET scan. C, urine catecholamines and metanephrines. D, bone scan. E, ultrasound-guided core needle biopsy.
Dr. Rosenbluth, while people are chewing on that one, on the last question, there was a question in the chat room about HIPEC. Is HIPEC an option in that ruptured tumor scenario?
Well, I will say I don't know that they're going to go into things like HIPEC too much for ABSITE since the indications of it are pretty specific. Additionally, Midotane is what you're using for higher grade adrenocortical carcinomas anyway. So that would be the answer, and HIPEC wasn't an option. Whether or not HIPEC is frequently used for that, I honestly don't know. Not something I deal with.
All right, back to this one.
Okay, back to this one. Yeah, you guys got it. So in this question, what we're most worried about really is a metastatic lesion given her symptoms and her history of renal cell carcinoma. And an FNA can confirm this, but this is one of those next best step questions, and you do not want to put a needle into something that could potentially be a pheochromocytoma, where it's going to cause a major sympathetic surge, so you want to check urine catecholamines as your first step. Okay, a 65-year-old woman undergoes a core needle biopsy for a suspicious right breast mass measuring 1.2 centimeters. The pathology is consistent with an ER-positive, PR-positive, HER2-negative invasive ductal carcinoma. The right axillary examination is negative for lymphadenopathy. She's planning to undergo breast-conserving surgery. Which of the following statements applies to the management of her condition? A, axillary node evaluation is not necessary when cancers are less than 2 centimeters and the physical examination of the axilla is negative. B, an axillary ultrasound is required prior to breast-conserving therapy. C, the patient requires systemic chemotherapy followed by adjuvant whole breast radiation therapy if breast-conserving surgery is chosen. D, a sentinel lymph node biopsy is not necessary if the patient receives systemic chemotherapy. And E, the woman requires sentinel lymph node biopsy at the time of surgery and adjuvant whole breast radiation.
And while people are chewing on that one, we had another question about that last question, the suspected pheo. Can PET be used as an option?
PET can be part of the workup, but the first thing that you're going to do before PET is those molecular markers.
Thank you.
Excellent. So this is the Z11 trial, right? Invasive cancer and a negative clinical node exam. You still need to test the node. A negative ultrasound is not sufficient because she's undergoing breast-conserving therapy. She's going to need radiation. And the use of chemotherapy depends on the characteristics of the tumor. You guys got it right. A 43-year-old woman undergoes core needle biopsy after a mammogram reveals architectural distortion of her left breast. Pathology reveals stromal fibrosis, so she undergoes excisional breast biopsy. Pathologic examination shows duct ectasia, squamous metaplasia, and a 4-millimeter focus of lobular carcinoma in situ, extending to the ink of the margin. Her grandmother and aunt both developed breast cancer after age 50. What is the most appropriate management? A, bilateral prophylactic mastectomy and radiation. B, high-risk screening with MRI and mammography. B, right partial mastectomy and radiation, C, re-excision to clear margins, or E, radiation therapy to the right breast. Yep, you guys are getting it. So you guys clearly know LCIS isn't precancerous like DCIS, but it's indicative of being higher risk, 7 to 10 times higher than the general population for invasive cancer. There is risk, but a prophylactic mastectomy is not necessary. It's not precancerous. You don't need a partial mastectomy or radiation. And this is one of the things that you do not need to go back for margins for. You just need high-risk screening.
All right,
guys.
Dr.
Good luck.
Thank you so much. That was a terrific review. Really appreciate it. All right, our next presenter is Dr. Nikhil Panda from Massachusetts General Hospital. He's going to cover a kind of a mixed bag of a couple of other topics from some of the surgical subspecialties in pediatrics, transplant, thoracic, and plastics. Welcome very much, Dr. Panda.
Thanks so much. Can everybody hear me okay?
Yes.
Okay, great. We'll get started. So the first question, and starting in pediatrics, is a 2-year-old child presents to the emergency department with abdominal pain and distension. The emergency department resident informs you that guaiac-positive stool was found during the initial workup. The child is in no acute distress. During the H&P examination, you learn that the child has had occasional bilious emesis during the past year that has not yet been evaluated. The patient is hemodynamically stable. How do you proceed? A, you order an upper gastrointestinal contrast study. B, proceed to the operating room for an exploratory laparotomy. C, proceed to the operating room for a diagnostic laparoscopy. D, order a CT scan of the abdomen and pelvis with contrast. And E, proceed with pan endoscopy to evaluate the guaiac-positive stools. Awesome. So I think all of us learn at some point in our training that any bilious emesis in a child needs an emergent evaluation, specifically looking for altered anatomy. And the differential that we're thinking about in this case is malrotation, things like duodenal and jejunal atresia, remembering that duodenal atresia occurs distal to the ampular vater. That's why we get the bilious emesis. But the one that we're really thinking about is the congenital malrotation that can lead to midgut volvulus. That can subsequently lead to torsion around the SMA and then can lead to lethal intestinal ischemia. So this is one of those things that I absolutely don't want to waste any time. But we can go on to the next question because I think almost everybody had a good sense of what we need to do here. So this next question, an 11-month-old child presents to the emergency department with abdominal pain and bilious emesis. The emergency room resident informs you that guaiac-positive stool was found during the initial workup. During the history and physical, you learn that the patient has had occasional bilious emesis during the past year that has not yet been evaluated. The patient is tachycardic and poorly perfused. The abdomen is tense. How do you proceed? A, order an upper gastrointestinal contrast study. B, proceed to the operating room for an exploratory laparotomy. C, proceed to the operating room for a diagnostic laparoscopy. D, order a CT of the abdomen and pelvis with contrast. And E, admit to observation with IV fluid hydration. Great. So in contrast to the last question, obviously the question stemmed here was trying to get us to recognize the difference between the prior patient who is in no apparent distress versus this patient who we're given information appears to be an extremis. And so the difference here is we don't proceed with first the diagnostic tool, but specifically to the operating room. There are a couple of pearls worth mentioning in terms of the ABSITE when it comes to what's going on with this patient and the last patient. The first is this history of occasional bilious emesis leading to this presentation. Is the story that we look for when we're thinking about congenital malrotation with these intermittent episodes of midgut volvulus, and then that episode of midgut volvulus that's creating the symptoms the patient presents with. In this patient, we're obviously worried about SMA compromise and intestinal ischemia. A couple of things that apply to both questions, the last one and this one, are what do we look for on that upper GI contrast study to let us know that it is a malrotation. And when we think back to embryology, the probably most sensitive sign that we might see is the fact that the duodenum does not cross the midline as we would see in an individual who does not have malrotation. When we do get to the OR, what we're looking to do is perform a exploratory laparotomy rather than the diagnostic laparoscopy for question C, because we're going to end up doing a counterclockwise rotation of the bowel. We're going to look for those filmy adhesions or LADS bands, which are part of the reason that this occurs. We're going to take those down, splay out the intestine, put the large intestine in the left abdomen and the small intestine in the right abdomen. And because we're intentionally placing these things where they would not be historically before the era of all the imaging modalities we have today, we would perform an appendectomy as well. Great, so we'll move on to the next question. A 12-year-old girl presented to the emergency room after a 24-hour history of right lower quadrant abdominal pain and nausea. Laboratory and imaging studies. Oh, I'm so sorry. I think we have different questions. We can do the one on your screen, sorry. So a 12-year-old boy underwent successful small bowel transplantation 9 months ago. He has suffered no signs of rejection, but recently has developed fever and cervical lymphadenopathy. Abdominal imaging reveals numerous enlarged mesenteric lymph nodes. What is the most likely diagnosis? A, acute cellular rejection. B, post-transplant lymphoproliferative disorder or PTLD. C, cytomegalovirus virus infection. D, disseminated aspergillosis. Or E, herpes simplex viral infection. Okay, great. Just a couple of comments about this one. So here we have a patient who had a hollow organ transplantation, but really any form of transplantation, one of the things we always think about are the fact that these patients have to be chronically immunosuppressed iatrogenically by all the medications that we're giving them. And therefore, all these patients are at an increased risk of developing malignancy. The most common malignancy in any transplant is non-melanoma skin cancer. And especially after small bowel transplantations, the second overall malignancy that occurs in any transplant patient is post-transplant lymphoproliferative disorder, or PTLD. We always think about the kind of B-type symptoms that might occur, so the lymphadenopathy, the diagnosis of mesenteric lymphadenopathy as well in this case. And then in terms of management, there are kind of three tenets to management. The first is, if possible, to decrease the immunosuppression, as that is the causative factor, but oftentimes that can't be done in patients who are transplanted. And so options include rituximab or monoclonal antibody against CD20 B cells. And then if that doesn't work, then the third line of therapy is CHOP-based chemotherapy. Okay, great. Next question. A 55-year-old man is being considered for living kidney donation. Which of the following would constitute an absolute contraindication to proceeding with donation? A, multiple renal arteries. B, diabetes mellitus. C, controlled hypertension. D, donor age older than 50. Or E, history of nephrolithiasis. Okay, great job. So all of these are situations where we would want to gather more information on that comorbidity in the living donor. The only absolute contraindication, according to the organ procurement and transplantation policies, or the OPTN, which sometimes we see on the paperwork of our transplantation patients on the wards, is diabetes. For the other answer choices, A, presence of multiple renal arteries is not a contraindication to donation, but that's one of the reasons why we often obtain certain contrast-based imaging, CTAs or CTs with IV contrast on our living donor patients, because we want to keep that in mind when we then go and perform the procurement from that patient. Hypertension requires further investigation to determine if it truly is controlled or not, but in itself is not an absolute contraindication. There's no absolute age cutoff, and the presence or history of Stone's disease is not a contraindication either. Okay, next question is: a kidney is being retrieved from a living donor, a 44-year-old healthy man. The period of time from the clamping and dividing of the renal artery to the flushing of the organ with cold preservation solution is known as which of the following? A, ischemia reperfusion time, B, warm ischemia time, C, cold ischemia time, D, preservation time, or E, procurement time. Great. So warm ischemia time is the correct answer here. So remember, the question's asking about the time between clamping and dividing of the renal artery in the living donor, and then ultimately preparing the organ on the back table, flushing it with cold preservation solution, and that's what we call the warm ischemia time. Properly, it's defined as the cessation of arterial inflow to the kidney to the time of preservation installation. The cold ischemia time, on the other hand, is the time from initiation of that cold perfusion to the time of reanastomosing and establishing arterial inflow in the recipient. The reason that we care about understanding the definitions about things like warm versus cold ischemia time is warm ischemia time is an important predictor whenever we consider expected postoperative organ function. And that's true for not just the kidney, but also other solid and hollow organ transplant. I think we have, there we go. I think we've covered that one. I think we've covered this question.
Yep, sorry about that.
Oh, no worries. Okay, great. Next question. So it's 8 weeks after liver transplantation. A 58-year-old man presents for routine follow-up. His post-operative course has been uncomplicated, and he has been maintained on Tacro, Celcept, or mycophenolate, and a tapering prednisone regimen for maintenance. Apologies for your screen there. I'm not sure if you can see the remainder of the question.
Yeah, sorry.
Sure, I'll just finish it here. In the clinic, he complains of fatigue, a low-grade fever, and myalgias, which have been present for the past week. On his lab evaluation, he has leukopenia and a mild elevation in transaminases. What is the most likely diagnosis? So A is a cytomegalovirus infection. B is cryptococcal meningitis. C is intra-abdominal abscess. D is post-transplant lymphoproliferative disorder, or PTLD. And E is acute cellular rejection. Okay, this is an interesting split here. The question stem included a few points that we can go over again, and I'll read them out loud that are to emphasize. So the first thing is the time frame, so 8 weeks after undergoing liver transplant. The second thing is that this patient in that time period is being maintained on a pretty typical dose of maintenance therapy in terms of immunosuppression, which is tacrolimus, Cellcept or mycophenolate, and prednisone. His symptoms, which are all initially seem nonspecific but are important when taken together, include fatigue, low-grade subjective fevers, some body aches, myalgias, and then his laboratory data tells us that he has leukopenia and a mild elevation in transaminases. So kind of going through some of these, the correct answer, as you can see, is A, is a CMV virus. So for meningitis, which nobody selected, we're obviously looking for some type of CNS-based symptom. For the PTLD, as we saw previously, some of these symptoms we could characterize as B-type, and we do know that PTLD is common in a transplant patient, but at least for the purposes of the ABSITE, we're really looking for a hint in terms of some type of lymphadenopathy. But I think one of the things that separates A from the other answers, it was that last bit of the combination of leukopenia with transaminases and then this kind of viral type prodrome. It almost sounds like it could be something like a hepatitis. And when CMV creates its viral syndrome in a transplant patient, there's really two types of phenotypes we think about, the hepatitis or a colitis. And in this patient, it was the elevation in transaminases that tipped me at least over towards A. A couple of additional points with CMV viral syndrome in a transplant patient is typically they're treated with ganciclovir. The other pearl here is an opportunity to review some of those mechanisms of actions of those drugs for the transplant patients, which always seem to show up on the ABSITE. So maybe after this, take a minute or two to review some of those high-yield points as well. Okay, next question, switching gears a little bit. A 67-year-old woman undergoes a video-assisted lobectomy for non-small cell lung cancer. Initial chest tube output is 1,500 milliliters per day of milky fluid. The fluid triglyceride level is 180 milligrams per deciliter. The patient is put on bowel rest, and total parenteral nutrition is initiated. On post-operative day 6, the output is 1,100 milliliters per day of milky fluid. What is the next best step in treatment? A is thoracoscopic thoracic duct ligation. B is to continue conservative management. C is thoracic duct embolization. D is initiation of antibiotics. Or E is talc pleurodesis. Okay, great. Let's talk about this one a little bit. So I think based off of the responses, many of us are seeing this, and I think this milky fluid after thoracic surgery is making us all concerned about an iatrogenic injury to the thoracic duct and the resultant chylothorax. What I think we also remember learning from our experiences on the wards is that about half of chylothorax patients do experience this because of iatrogenic injury during surgery, and the other half is maybe somebody who's presenting with a lymphoma. The diagnosis is kind of confirmed whenever we test the pleural fluid for triglycerides. We look for a threshold of greater than 110, and that's really the one that is, at least for the purposes of the ABSITE, the most diagnostic. In reality, we're also getting the other tests like protein and pH. The management of a chylothorax is kind of what's been described in the patient's question stem. First is maintaining drainage, and in most of these patients who have iatrogenic injuries after thoracic surgery, they already have a tube in place, but that drainage is important to quantify the amount of fluid that comes out, obviously also to evacuate the fluid in terms of pulmonary function. The second is to provide bowel rest, NPO and TPN. And then the rest can be watchful waiting, sometimes for weeks. But the important thing for this patient is that the patient starts with 1,500 milliliters per day, and despite any effort to try and control that, the change only goes down to 1,100 milliliters per day. And then we have to also be thinking, well, when is the best time to potentially reoperate? This is a tough question because oftentimes what we see on the wards and what we see done in real practice and what we see on the ABSITE can be different. And so, for instance, some institutions, the preference is to go straight to thoracic duct embolization. But at least for the references used for these questions and the score questions, the thoracic duct embolization or coil embolization with interventional radiology is typically still reserved for patients who have a significantly high burden of comorbidities. The most definitive treatment, again, based off of the resources provided for these questions, is to do a thoracic duct ligation, which can be approached, again, minimally invasively and in the lower right chest, where the thoracic duct enters from the abdomen. Great. Next question. So an 88-year-old woman with oxygen-dependent COPD, coronary artery disease, systolic heart failure, diabetes, presents with shortness of breath worsened over 2 weeks. Chest X-ray shows a large left-sided pleural effusion and mediastinal widening. CT of the chest shows significant diffuse lymphadenopathy, including bulky mediastinal lymph nodes. She undergoes a thoracentesis. This reveals milky fluid. The pleural studies confirm the presence of a chylothorax, and a chest tube catheter is placed. After 7 days of conservative management, daily outputs are 1,300 milliliters. What is the next best step in management of this patient? A, continue conservative management for 2 weeks. B, place a second chest tube. C, thoracic duct ligation. D, open thoracic duct ligation. And E, thoracic duct embolization. Great, and I know we just covered this on the last question, so we won't discuss it for too long. But again, the difference between the last person and this person are two things. One, the underlying diagnosis. The last person had an iatrogenic thoracic duct injury during a VATS procedure. In this procedure, this patient might be presenting with, say, a lymphoma, and that is the source of the chylothorax. And then the second thing are the burden of comorbidities, guiding us down towards a more minimally rather than maximally invasive approach. Okay, next question. A 53-year-old man with a 40-pack year smoking history presents to the emergency department reporting shortness of breath and bilateral upper extremity swelling. The contrast-enhanced CT of the chest reveals a right upper lobe lung mass. He undergoes a CT-guided biopsy that confirms the diagnosis of lung cancer. What should be the next step in his management? A, video-assisted thoracoscopic resection of the right upper lobe. B, thoracotomy with right upper lobectomy. C, radiation therapy, or D, chemotherapy. Okay, so yeah, let's talk about this one. So the correct answer is radiation therapy. So the takeaway here is that the patient is presenting, the underlying diagnosis is provided to us, which is right upper lobe lung cancer, but the phenotype is a superior vena cava syndrome. So this cancer is likely invaded or significantly compressing the superior vena cava, and as a result, we get that phenotype of shortness of breath and bilateral upper extremity swelling. Sometimes in other questions, or if you've seen one of these patients on the ward, they can have things like plethoric facies because of the congestion or the reduced venous return from the head and neck. And depending on how rapidly progressing that mass is, we can see other things like dilated collaterals form underneath the skin and on the upper chest, or at least some telangiectasias. But the most important thing to think about is that these tumors do have that kind of pattern of rapid progression. And so the most important goal in treating these patients is to try and shrink that locally aggressive and invasive disease. And the most effective way to do that is radiation therapy. Remember, we think about radiation as being used for local treatment and systemic therapy or chemotherapy being used for systemic or distant treatment. And for those reasons, chemotherapy would not have been the best choice in this particular case. Now, some practice questions that we see might have an option of both chemotherapy and radiation, and still the best answer would be radiation therapy because we know based off of studies in these patients that chemotherapy does not have a survival advantage. Now, the next question is why don't we go to the operating room? And we have to think about what we would do when we get there. So we have, again, a tumor invading or encasing the superior vena cava. And what we would end up doing to be able to provide that patient with the best possible oncologic procedure would be end up resecting a major vascular structure from in terms of the great vessels. And so immediate surgery would be associated with extremely high morbidity and mortality. Okay, next question. A 55-year-old woman with a history of colon cancer resected 4 years ago has a new 1.4 centimeter left upper lobe nodule found on CT. Metastatic workup is negative. A video-assisted thoracoscopic wedge biopsy shows squamous cell cancer. What is the next step? A, terminate the procedure and plan for 5-FU-based chemotherapy. B, terminate the procedure and plan for no adjuvant therapy. C, sample the lymph nodes and obtain a wider margin. D, perform a completion lobectomy. And E, perform mediastinal lymph node sampling. Okay, great. Decent spread here. So let's unpack a couple of things. There are a few pearls. So the first pearl is the STEM is trying to get us to think about, could this be a history of colon cancer with isolated either lung or sometimes we see in questions liver metastases. And what we know is that if patients have isolated metastases in the lung or the liver, then we can resect those if it's in association with, say, colon cancer. Sometimes, we're asked questions like, can you do those at the same time? Can you do it in sequence? And there's no evidence to say what is best. And so oftentimes we resect the colon cancer because it's symptomatic. People either have bleeding or obstruction. But here we're thinking, okay, we're going to do a metastectomy. We're going to resect this isolated lung cancer. But what we find is on the wedge resection that it's not a metastatic lesion from the colon adenocarcinoma, but it is a second primary squamous cell carcinoma. Based off of the size and the situation, the most correct answer would be to perform a completion lobectomy. So the size cutoff in terms of T stage for this cancer and the fact that during the metastatic workup, which we would assume included maybe a PET scan, there was nothing else that was FDG avid, we can assume that this primary lung cancer might be either local or at most local regional, and so we would perform that completion lobectomy. If we were not working up this cancer in operation, let's say that we had a CT scan first, then we would be thinking about maybe doing a mediastinal staging or lymph node sampling. Great. Next question. A 60-year-old man, an active smoker, presents with a cough. A CT scan demonstrates a 4-centimeter right upper lobe mass and enlarged right hilar and paratracheal lymphadenopathy. What is the next step? A, right thoracotomy, right upper lobectomy, and mediastinal lymph node dissection. B, a cervical mediastinoscopy. C, a CT-guided fine needle aspiration of the lung mass. D, an MRI of the brain. Or E, a cardiac stress test.
some discussion on this one.
Yeah, okay. So the question stem is trying to get us to think about a smoker who comes in and has an imaging study done. Maybe it was a screening CT scan or a CT scan for another reason. And the most concerning features, in addition to the fact that we suspect a lung cancer, is that has that lung cancer progressed to local regional disease, specifically going from just the lesion itself to the mediastinum or hilar lymph nodes. And so one thing that might be worth reviewing is just how do we work up a patient who has lung cancer after we get past the history, physical exam, et cetera. So the most important thing that guides management is the status of their mediastinum. So when we think about the staging of these tumors when nodal disease, N1 is any ipsilateral hilar lymph nodes, and N2 is any ipsilateral mediastinal lymph nodes. And if you have a positive N2 node or a positive mediastinal lymph node, then your tumor is no longer considered immediately resectable, and you have to undergo neoadjuvant systemic therapy. And so the most important next step for us in guiding this person's treatment is to actually stage that mediastinum. Now, imaging findings alone cannot stage the mediastinum positively. So if you have a PET scan, even in this case, beyond just a CT scan, and the PET scan showed that these nodes lit up, you would still want to perform a cervical mediastinoscopy or an endobronchial ultrasound, should that have been an option, to get a positive tissue diagnosis. And the reason is that in some cases, those nodes might be reactive just from, let's say, that lung mass causing a distal airway obstruction and some inflammation associated with that atelectasis. And so the real important point here is what guides this person's management is staging the mediastinum to evaluate for N2 disease. There's a question that just came up in the chat room that says, have I seen questions where both a mediastinoscopy and EBUS are options? How would you decide which if both were given? So the only thing I have not seen them. The only thing I can say is if maybe you are taking like a thoracic surgery level type test, they might give you a particular station that you're trying to access, in which case, cervical mediastinoscopy can access a certain set of stations. EBUS can usually get farther into the lung, into the hilum. And then lastly, there's Chamberlain procedures, left parasternal incisions that can access a different set of nodes. But I think, I hope, I'm going to take the ABSITE next week too. I hope that's not on there. One more question here. We've got a 43-year-old firefighter has mixed second and third degree burns over 80% of his body surface area. 3 days after successful resuscitation and bilateral or lower extremity escherotomies, you're contemplating excision and coverage of his lower extremities. Which of the following is the best option? A, full thickness autograft, B, split thickness autograft, C, allograft, D, xenograft, and E, secondary intention. Okay, great. So let's talk about this one. So a 43-year-old firefighter, second and third degree burns over 80% of his 80% TBSA. So absolutely right. In general, when we think about trying to get to early excision and grafting, really we're always thinking about between options, let's say A and B in this case, like a full thickness autograft or a split thickness graft. And a full thickness autograft, what we're thinking about are usually ones that are like taken from the inguinal crease. We see them used a lot in hand, face and neck, like those types of areas. They have different primary versus secondary contraction properties compared to autograft. But for the vast majority of the big burns that we see, we usually try and autograft these patients immediately. This wasn't kind of meant to be a trick question, but probably the most important part was just appreciating the fact that this type of patient has probably very, very little areas where you can harvest skin to autograft. And so what we think of then is using something like allograft to temporize and provide a base layer and allow some of the other areas to potentially heal, and then do sequences of autografting. where we do go and get autografts, use and create split thickness skin grafts and place them on the burns and leave other areas allografted until we can go and reharvest once again. There have been some case reports that come out where you can hear stories of people having like 98, 99% burns, and over a series of several months, areas like the top of their head, which have been spared, or even their feet, can be the sources of prolonged autograft. So again, the reason in this particular question that C was the best answer was just because probably trying to go and allograft the entire body all at once is unlikely. So then the question is why couldn't split thickness autograft still be the right answer and just in sequence? Well, you still don't want to sit there and have all these burns open and then become susceptible to insensible losses and infection. And so you have to cover it with something. And so that is, again, why allograft is better than even an Antler-like sequential split thickness autografting.
That was a tough question, but a very good explanation. And thank you for really an excellent review and discussion of a wide variety of topics, Dr. Panda. Thanks so much for joining us tonight.
Of course. Thanks for the time. Good luck.
All right. Now our final section is going to be on vascular, another high-yield topic. And we're very fortunate to have Dr. Jerry Fortuna with us today, vascular surgeon from WashU here in St. Louis. Dr. Fortuna, welcome, and thanks so much for being with us.
Yeah, thanks, Mike. Can you hear me okay?
Yes.
All right, so we'll start off here. A 64-year-old woman with atrial fibrillation off of anticoagulation presents with diffuse severe abdominal pain of abrupt onset. She's tachycardic with a blood pressure of 90/60 that improves with crystalloid boluses. Examination is significant only for mild tenderness to palpation without rebound. Laboratory studies are noted for a leukocytosis, elevated lactate, and normal serum creatinine. What is the best imaging study to obtain at this point? A, abdominal ultrasound, B, CT angiogram, C, conventional angiogram, D, upright and supine abdominal x-ray, or E, MRA. All right, yep, very good. So it looks like just maybe a little bit, we can run through the answers real quick. An abdominal ultrasound probably is not going to give you a lot of information in this setting because it's user dependent, and body habitus with overlying bowel gas may keep you from seeing what you want to see. Conventional angiograms, you could go to the operating room and would afford you an opportunity to maybe both be diagnostic and therapeutic, but probably is not necessary right off the bat as your first line, as it can take a long time, and ultimately you may not be able to perform your therapeutic interventions, and an MRA would take too long in most hospitals to set up, but is a good option from an imaging, but I think the best is CTA right off the bat to begin with. An 82-year-old man with hypertension, hyperlipidemia, severe chronic obstructive pulmonary disease with oxygen dependence and ischemic cardiomyopathy with an ejection fraction of 20% develops acute abdominal pain. A CT angiogram demonstrates a 1 centimeter ostial superior mesenteric artery occlusion. His aorta is moderately calcified throughout, and he has moderate calcific stenosis of the celiac with an occluded inferior mesenteric artery. What is the best treatment? A, antegrade mesenteric bypass, B, retrograde mesenteric bypass, C, systemic thrombolysis, D, retrograde open mesenteric stenting, E, superior mesenteric artery angioplasty and stenting. Okay, good. So a little bit of a smattering all over. We can kind of go through what makes the last answer the best. And I think the hints really are in the question itself as you look at things. Number one is the age of the patient, 82-year-old with significant comorbidities, to include the ischemic cardiomyopathy and an EF of 20%. So I think that's really going to drive you from there on eliminating some of these open procedures. So that takes away A and B, as the patient may not be able to tolerate a procedure. Okay, and then also it gives you good hints in there that the aorta is moderately calcified throughout, which makes it hard to do an antegrade bypass. He definitely needs something. Thrombolysis is going to be difficult because it's completely occluded, and especially within an SMA, you don't want to shower things distally over time. And so we've eliminated those other kind of procedures, so I think the best thing is to proceed with a diagnostic angiogram and then possible stenting. And then I see here on the thing, can you stent an occluded vessel? The answer is yes, if you can get a wire past it. Okay. 75-year-old man is in the intensive care unit one day after a complex valve replacement and coronary artery bypass. He is taking multiple high-dose vasopressor agents. A CT angiogram obtained to evaluate a rising lactate level demonstrates patent but diffusely constricted superior mesenteric artery. What is the best therapeutic option? A, superior mesenteric artery thromboembolectomy. B, retrograde mesenteric bypass originating from the left common iliac artery. C, antegrade mesenteric bypass originating from the supraciliac aorta. D, catheter-directed thrombolysis. E, supportive care. Very good. So this is kind of a classic question that you're going to get, and it's just an understanding of non-occlusive mesenteric ischemia. They set the question up very nicely. This is a very sick patient that was admitted for something else, undergoes a procedure, now is on high-dose vasopressors, which is going to cause vasoconstriction within the mesenteric vessels. It's giving you that you're having some ischemia, and what this patient really needs is resuscitation, and get the patient off of their vasopressor agents and then see how they're doing. What you don't want to do is try to perform some sort of procedure in somebody who's constricted and already sick and cause them to have a bigger problem. A 72-year-old woman with congestive heart failure, ejection fraction of 30%, presents with unremitting abdominal pain of acute onset. She has a history of chronic mesenteric ischemia treated with a superior mesenteric artery stent. She has been treated twice for in-stent restenosis. A computed tomography angiogram shows an occluded SMA stent with reconstitution of the distal SMA. What is the best option for SMA revascularization? A, percutaneous angioplasty. B, retrograde open stent. C, supraciliac aorta to SMA bypass. D, common iliac artery to SMA bypass. Or E, renal artery to SMA bypass.
Okay. Discussion on this one.
Yeah, we're all over the place here. Okay. So I think the key again is, really read these questions carefully because they're giving you a lot of information up front. So number one, you've got an older patient, and this is old even by vascular standards, so kind of keep that in mind, okay? And their EF is 30%, so you've got a bad pump. So you have to keep in mind that anything open that you do and any kind of a bypass coming off the aorta at this location is going to cause you to have a supraciliac clamp, which is very stressful on the heart because you increase the afterload that the heart has to pump against during that time of the clamp. And so that's really tough for patients to tolerate who are this old and this sick. And then it gives you kind of some additional information that endovascular attempts already failed multiple times. So you probably wouldn't expect a different outcome to continue down this road. So she needs a bypass of some sort. And that really narrows it down to your bottom two answers, of which the common iliac artery is a better inflow to provide to your intestines than a renal artery bypass. So that's where we get to D. Does that make sense to everybody? How many times would you try endovascular before going open? I would say, you know, doing a repeat procedure, so you know your initial and then a repeat intervention. If this has gone down 2 or 3 times, you probably don't want to go back and try this again in somebody this sick where it's failing, especially when, you know, acute thrombosis of these stents like your SMA really have a high morbidity and mortality level with dead gut and things like that. So you want to try to fix her inflow as best as possible. And then again, why not the supraciliac aorta? As I said, to bypass off the supraciliac aorta, you have to put a supraciliac clamp on. And that clamp is very hard on patients that have poor EFs because it increases the afterload. Okay. Contrast nephropathy is a concern in many patients, especially those with pre-existing renal insufficiency. Which of the following is recommended to reduce the risk of contrast nephropathy? A, avoid selective catheterization of vessels. B, hold angiotensin converting enzyme inhibitors preoperatively. C, hold metformin prior to endovascular procedures. D, pre-medicate the patient with steroids. E, use only hyperosmolar contrast agents. Okay, so just running through the stems again real quick here. Avoiding selective catheterization of vessels. It's actually a good thing if you can selectively catheterize because it limits the amount of contrast you have to give patients to see what you want to see. Holding angiotensin converting enzymes or ACE inhibitors increases increases the risk of contrast-induced nephropathy. This is the only one there, and you should normally be stopped the day prior if able when you're doing these. Metformin, we hold really for the risk of metabolic acidosis, not for contrast-induced nephropathy. And the pre-medication of patients who are on steroids really has no effect when it comes to contrast-induced nephropathy. Okay. So we good there? So really it's just the ACE inhibitors, and remember that when you're setting those up. On postoperative day 1 following a right-sided carotid endarterectomy, a 68-year-old man has right-sided tongue deviation on physical examination. Which nerve is most likely involved? A, vagus nerve, B, hypoglossal nerve, C, spinal accessory nerve, D, marginal mandibular branch of the facial nerve, E, superior laryngeal nerve. All right, good. So everybody's pretty tight on this one. It helps. We can review this real quick if you'd like. But kind of risk factors for cranial nerve injury on de novo or virgin necks is probably somewhere in the neighborhood of about 3 to 5%. For recurrent endarterectomies or recurrent neck exposures, that risk goes up almost to 20%, if not maybe a little higher. Okay. So it's important to realize that, and that may come into play if they're asking you about redos in comparison with carotid stenting, and so that's now an indication for carotid stenting. All right, we'll move on to this next question. A 62-year-old man is undergoing open repair of a juxtarenal abdominal aortic aneurysm through the transperitoneal approach. Which of the following structures must be mobilized to isolate the supraciliac aorta for clamping? A, duodenum, B, left renal vein, C, left lobe of the liver, D, caudate lobe of the liver, E, left ureter. All right, so this is kind of just a knowledge of anatomy. So to perform a supraciliac clamp, you need to be in the abdomen or the peritoneum and not in the retroperitoneum. That portion of the duodenum at this level is the retroperitoneal structure, and you don't need to do a Coca maneuver to move that out of the way. You're going to be cephalad to that and more anterior, if that makes sense. The left renal vein is below where you want to be. So the left renal vein is important to see if you're exposing the infrarenal abdominal aorta. The caudate lobe should be more lateral. You're going to be more medial right on the spine. And the left ureter is really completely out of play. So the left lobe of the liver is the only thing you need to do for exposure to be able to bring that up. And frankly, in some patients, you don't have to move that out of the way either. You're going through the gastrohepatic ligament. You are about to gain percutaneous femoral artery access for a diagnostic and possible therapeutic angiogram on a 70-year-old man with claudication. Incorporating which of the following routine steps will help reduce access site complications? A, ultrasound to guide needle placement and avoid atherosclerotic plaques. B, limited cut down in diabetic patients to reduce postoperative hematomas. C, withholding antiplatelet agents to assist with hemostasis. D, use of vascular closure devices at the end of the case. E, reversal of heparinization with protamine administration. All right, pretty good. So just to address some of the misses, I mean, really when you're looking at this, it's asking you how can you see things better to perform it safer? And the only option in here really is the ultrasound guided access. Use of vascular closure devices, that's at the end of the case, so we already would have gained access, and really using closure devices, some would argue, increases your risk of access site complications because they all have failure rates. Certainly we reverse if we're given heparin most of the time, but that's not associated with decreasing complication rates with appropriate pressure, and the same thing with withholding antiplatelet agents. All right. A 70-year-old woman is being transferred to your hospital with a ruptured abdominal aortic aneurysm. You discuss with anesthesia and the operating room staff how to most safely and expeditiously treat her. You decide to do which of the following? A, immediately induce general anesthesia to facilitate patient exposure and secure the airway. B, administer blood product and crystalloids to maintain blood pressure in the normal range until setup is complete. C, have extra staff available to assist in quickly turning the patient for a retroperitoneal approach. D, prep the patient's skin after induction of anesthesia to avoid patient hypothermia prior to incision. E, have at least 3 aortic excluding balloons available so that aortic control can be established percutaneously. Okay, good. Except we're kind of all over. All right. So for A, you don't want to immediately induce general anesthesia in someone who you're concerned about having a rupture and likely already hypotensive. What this can do is generate cardiovascular collapse as you relax the patient. You take away all of that sympathetic response that's actually keeping them alive. Oftentimes with ruptured aneurysms, we do these endovascularly, and we approach them with the patient completely awake under local and would monitor anesthesia care to help prevent this with suitable anatomy. Otherwise, you have to try to get control first and then go from there. And that'll lead into that bottom answer here shortly. You don't want to give blood pressure or blood products or crystalloids to raise the blood pressure. This is just like trauma. You want to generate permissive hypotension. So it's okay to give some blood products, but you don't want to make them normal, or else you can actually, quote unquote, pop the clot, and it can make your situation worse, much like answer A. C, you're probably not going through a retroperitoneal approach, and really you don't need help turning, you need to get control. And along those same lines for answer D, if you were going to proceed down this route, you'd want to have the patient prepped prior to, not after induction. That way it would facilitate you moving faster. So really the right answer is E, to get a balloon up and stabilize blood pressure and then let you fix the problem. A 47-year-old woman with a history of migraine, headache with aura and left limb varicose veins has presented microphlebectomies and ultrasound-guided foam sclerotherapy. 2 minutes after the procedure, while walking out of the room, she starts complaining of nausea, headache, and visual disturbances or scotomas. What could be this patient's most likely underlying diagnosis? A, allergic reaction to the sclerosant agent. B, vasovagal reaction. C, structural heart disease. D, common side effects seen with tumescent anesthesia. E, conversion disorder. Okay. So an allergic reaction to the sclerosing agent is possible, but would not likely give you the symptoms that she's having here. This makes you worry that you've had something cross from the venous to the arterial system to be able to give you these kind of end vascular bed type symptoms. Okay, so that's what they're really trying to drive at. Same thing with vasovagal reaction. You're not going to get those kind of symptoms. Structural heart disease is the answer, and what they're really wanting you to pick up on is this patient likely has an undiagnosed PFO, and so you've had something embolized from the venous system through the right side of the heart to the left side of the heart, and now is going up and giving you almost stroke-like symptoms. And the same thing, it's just not a complication of the tumescence. Tumescence is local anesthetic with some bicarb that we're putting into the subcutaneous tissue to help with bleeding. A 64-year-old female presents to your office for evaluation of a swollen left lower extremity extending from the inguinal ligament distally. She underwent an isolated left lower limb perfusion for a history of malignant melanoma. She denies pain but endorses night sweats. What is your most likely diagnosis and imaging study? A, May-Thurner syndrome, iliac vein duplex. B, lymphedema tarda, CTA. C, pelvic adenopathy, CT of the abdomen and pelvis. D, great saphenous vein reflux, venous duplex. E, Stewart-Treves syndrome, lymphoscintigraphy or lymphoscintigram. Okay, and so we're all over kind of the map here again. So really, May Thurner is chronic occlusion of the left iliac vein. This could be possible in this setting, but I think with the information that you're provided in the STEM with prior malignant melanoma and lymphadenopathy within the groin, you're looking for compression within there. It gives you some information about you know, the ultrasound, and you need to really look at where that left common iliac vein is and whether or not you can see it with the ultrasound, and it could be difficult. It's not lymphedema tarda, and so that's not going to help you. You don't want to worry about the superficial system, so D's not an answer. And Stewart-Treves, this is not a primary lymphatic problem, so that doesn't go together. So really what you want to do is go back to where the money is and what her prior diagnosis is, and you want to do that with the CT of the abdomen and pelvis and see if you have external compression on the iliac vein. So that's the best kind of pathway to tease this out. A little bit of a hard question. So the next one's a 36-year-old woman who presents to your office with bilateral lower extremity edema. The overlying skin is not tense and is non-erythematous. Symmetrical distribution of fat is located between the hips and the ankles. The feet are not involved. You can pinch the skin easily and lift it at the base of the second toe. What is your management plan? A, weight loss. B, leg elevation. C, venous ablation. D, lymphatic bypass. E, compression stockings. Okay, yep, this one is really tough in that what they're trying to do is tease out the difference between lymphedema and lipedema. And they kind of give you the information you need right there, which is pinching the skin easily and lifting it at the base of the second toe. This is called Stemmer's sign, and it's pathognomonic for lymphedema. That's Lipedema. And so therefore, the only answer that's correct on this is A. A 72-year-old man is admitted to the ward with dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. He is noted to have pitting edema in bilateral lower extremities. His right leg feels larger than the left. He denies chest pain or pleurisy. He has not used compression stockings in the past. How will you proceed with investigation? A, bilateral lower extremity venous duplex. B, echocardiogram. C, computed tomography angiogram of the chest. D, captopril challenge. E, photoplasmography. Okay, so almost split 50-50. I think the big thing here is they're giving you in the STEM that the patient has significant cardiac problems, and they don't really give you anything about whether or not the patient has previous venous insufficiency. And so for that, it would be most appropriate to work them up with an echocardiogram, and then that would guide you on whether or not you need to continue down a venous insufficiency pathway.
Dr. Fortuna, thank you so much for guiding us through this excellent review of vascular topic. Just a really amazing depth and breadth of knowledge. Thank you so much.
Yep, thank you so much.
Thank you. And I want to thank really all of our faculty this evening for guiding us through this tremendous ABSITE review. We really are fortunate to have so many folks that were on the call, over 1,000 folks worldwide joined us tonight. Want to just remind everybody about taking a survey. We really appreciate your feedback, and year after year we incorporate your feedback to make even our next sessions better, including having 2 sessions this year was a result of your feedback. So please take a minute to fill out the survey. Think about joining us at SAGES in the spring in Cleveland, Ohio. We'd love to see you there. And last but not least, I want to thank everybody for joining us and wish everybody good luck on the upcoming ABSITE exam coming up in a couple weeks here in the U.S. Thanks again, everybody, and have a good evening.